This class, we're going to be talking about how disease is distributed in populations. We will be discussing incidence and prevalence, and also we're going to talk about the natural history of disease, which we'll revisit more in future classes. This shows a way of conceptualizing how disease is distributed at the population level. At any time, most people in a population are well, and a smaller proportion of those are sick. And of the people who are sick, even fewer people will actually seek care for their illness, and an even smaller portion of those will be hospitalized. The people who die of an illness are spread throughout all of those groups. Most people may have been hospitalized before dying, but there's also people who sought care and may have been seen at a clinic or primary care practice, and there's people who were sick at home, and there's also people who die who didn't even know they were sick before they died. At the individual level, each disease has a different natural history. So we always need to consider when the biological transition from well to sick occurs, and we need some time with the disease process for there to be lead time before most people will be diagnosed in order for a screening program to be possible. If people only become very ill and then they're immediately diagnosed, we wouldn't be able to do screening. We need that time in the disease process where we can catch people who don't know that they have the disease yet, and at that early stage, we can intervene in order to prevent progression of disease. HIV is an example of a disease with a very long natural history. Even without treatment, there's often a preclinical phase of about 10 years before someone would progress to having AIDS. So in that example, people don't even have symptoms for perhaps a decade in some cases. But during that time, someone could be tested, and then we could provide health interventions that would prevent the person from progressing in their illness. Understanding the natural history of a disease is helpful for prognosis, but it's important to keep in mind that this is different for each disease and also varies between individuals. And time of diagnosis is influenced by someone's access to healthcare and could be influenced by other factors as well. So how do we quantify cases of disease? Incidence indicates the risk of disease, while prevalence indicates the burden of disease. Incidence measures the rate of new cases of disease occurring in an at-risk, disease-free population. And with incidence, the denominator is at-risk people only. But for prevalence, both healthy people and people with the disease are included in the denominator. Incidence rate is a true rate because it includes time in the denominator, usually expressed as person years, but it could be person months or some other time interval depending on what you're studying. You will see cumulative incidence, which is a proportion. So that one is a little confusing because it has the word incidence in it, but it's actually not a rate, it's a proportion. It's new cases occurring in a specified time period divided by the people at risk for that disease during that time period. So it's a little bit different from prevalence because the people who already have the disease are generally excluded compared to prevalence, which keeps the whole population in the denominator. Counts, which are just the number of cases, are helpful for very rare diseases because the incidence rate or prevalence would both be very low. For prevalence, we divide the number of cases prevalent in the population at a specified time by the total population during that time period. Prevalence is often the most useful measure for determining resource allocation. For example, if we want to determine how much of a health department's money should be spent on diabetes care, prevalent cases would be helpful data to guide budgeting for health programs. Although this is less true for diseases or events that have a short duration and high fatality. Something may be significant from a public health standpoint, but might not contribute much to prevalence if people don't live very long after they're diagnosed, or if the illness or condition only lasts for a very short time. Here's a practice question. If 20% of the participants enrolled in a study are lost to follow-up by the time the study ends, how will this affect person time? Will it increase, decrease, or stay the same? It will decrease because we would have less person time contributed to the denominator. Here's another practice question. Is prevalence a rate? No, it's a proportion. People sometimes say prevalence rate, but please try not to say prevalence rate because it's not technically correct and it just is really confusing. Incidence rate is a rate because it has time in the denominator, but prevalence does not. A proportion is when you're dividing two numbers where the numerator is a subset of the denominator, and a rate has to have time, such as person time, in the denominator. In this example below, the blue dots on the left each represent one person. So we're looking at 10 people over these years, and the purple lines represent when a person had the condition under study. The purple is the duration of disease. Here's some more practice questions. What is the point prevalence in 2017? So you're going to find 2017 and then which of the purple lines would be included in point prevalence and what would your denominator be? For that one, because it's prevalence, we're going to include all 3 of those cases that were present in 2017. They were prevalent cases. And the denominator is all 10 people. It's the whole population. So it's 3 divided by 10 times 1,000 for a point prevalence of 300 per 1,000. What's the period prevalence from 2016 to 2020? For period prevalence, we're going to include all 5 because it's all of the cases that existed during that time period. And our denominator is still all 10 people in the population. What about the incidence rate for 2018? We're only going to include one case because incidence only is new cases. So those other 2 purple lines that bisect the 2018 study don't count in incidence rate because they were prevalent cases, not new cases. In reality, there are certainly infections that you can get more than once or even at the same time, but a lot of the time in epidemiology, people are excluded if they already have a diagnosis of the condition under study, even if technically they might still be at risk of getting it again. So it's 1 divided by 8 times 1,000 is 125 per 1,000. If we assume it's a disease you cannot get more than once, such as the chickenpox, we would leave out both those 2 prevalent cases and that case that already happened in the past because that person would be no longer at risk of the disease. What about the cumulative incidence from 2018 to 2020? Cumulative incidence is the probability of developing a disease over a specified time period. So it's an estimate of risk. And because of that, if someone would not be considered at risk of developing the condition, they don't get included in the denominator. So for cumulative incidence from 2018 to 2020, we would subtract the 2 prevalent cases in addition to that case that happened during the 2016 to 2017 period. Because for most conditions, we wouldn't count them as being at risk of developing the condition of interest. So we would divide the 2 new cases by the 7 people out of the 10 who were still considered at risk. So the cumulative incidence would be 29% from 2018 to 2020 in this example. For incidence rate, we're dividing new cases by person time. So think back to my example in the previous class where there's 1 man shoveling snow for 4 hours versus 4 men shoveling snow for 1 hour each. It's the same amount of person time contributed in those 2 cases. In this example, We have 10 people again represented by blue dots, and everybody is pulled back to the starting line in 2020. So you can see how the person time contributed by each study participant compares. The people who are teal are those who were diagnosed with the condition of interest. Each line terminates if the person was lost to follow-up or dropped out of the study. So this is a pretty realistic example in the sense that most people in long-term studies don't stay for the entire duration of the study. A lot of people move or they decide that they don't want to be in the study anymore. So it's pretty common that you end up having to add up person time contributed by different participants that's of variable duration. What is the incidence rate of xylazine-induced skin ulcers per 1,000 person years among people who inject drugs over the duration of this study? 3 people developed the condition of interest, and to get the total person years contributed, you just add up each line to see how many years count. So for this example, I said it was being assessed at annual exams. So we're not going to count partial years for this, but that's not always the case. In real epidemiologic studies, there's many statistical methods used for including half years or other partial years, so we don't completely lose the people that don't participate in every single year. But in this example, don't worry about that. Only count if they actually were seen at the annual exam. So going from the top down, we've got 1 plus 2 plus 4 plus 4, etc. And we're going to add those up to get 21 person years contributed. And then we divide the 3 people who developed the ulcers by the 21 person years to get 143 per 1,000 person years. Something else I wanted to point out about these last 2 examples is that the reason we wouldn't just throw out the data from people who dropped out of a study partway through isn't only because that would decrease our sample size. It's because excluding those people who we followed for some length of time who didn't develop the condition of interest would make us overestimate the incidence by incorrectly removing them from the denominator. 1,000 infants were born at ANMC. 200 infants were born with neonatal abstinence syndrome, and 15 of these 200 contracted measles during the first year of life. 70 of the 800 remaining infants also contracted measles during the first year of life. What is the cumulative incidence of measles in this population? We would divide 85 by 1,000 because it's 15 plus 70. The total cumulative incidence equals the number of infants who got measles, regardless of whether or not they had neonatal abstinence syndrome, divided by the total number of infants born. 1,000 elders sign up for a new wellness program in 2024. Everybody's blood pressure was checked 2 times on separate days. 120 had a blood pressure above 140/90 on both readings. 400 had a previous diagnosis of hypertension in their medical record. During the 1-year program, 10 people develop hypertension. What is the hypertension prevalence at the end of the program? Prevalence includes cases in the population that were pre-existing, and the denominator includes the total population, both people who have and don't have the condition. So we add the 120 people who were diagnosed with hypertension at the beginning of the study with the 400 people with pre-existing hypertension, so 520, plus the 10 people who are new cases of hypertension for 530. This is a way of thinking about the relationship between incidence and prevalence. As new cases are added, they become prevalent cases, and when people with the disease are cured or die, represented by getting poured out into a glass, they cause the volume of prevalent cases to decrease. If new cases are occurring at a constant rate and cures and deaths are also occurring at constant rates, the volume of sangria would remain the same, so there would be no change in prevalence. So prevalence is about equal to the incidence multiplied by the duration of disease, but this is only true if both incidence and duration of disease remain constant. This wouldn't be accurate anymore if the rate of cases being diagnosed changed, or if an advance in treatment caused an increase in the rate of people being cured, for example. Prevalence can also be affected by immigration. The prevalence would increase if your population has a lot of healthy people leave, and it would decrease if a lot of people with the disease moved away. If you're looking at a rare condition and your geographic location includes a referral hospital, that's something you should keep in mind. As an example, if everyone with pediatric cancer from the whole state of Alaska is getting treated in Seattle, then the prevalence in Alaska might be artificially lower if all of those children are living in Seattle while undergoing treatment. This graph shows HIV prevalence and incidence in the US. Can you label the lines? What's been going on with HIV in the US since 1980? Have an increasing number of people been getting infected with HIV over time? HIV is an example where the treatment has improved so much over the years that people aren't dying of HIV anymore. So the prevalence in the US has been increasing steadily, while the incidence has remained fairly stable over the years. What if this were an unknown disease and the labels were reversed? What might be going on? Maybe people are getting infected and dying so they don't become a prevalent case, or maybe the disease has a short duration. This example is based on a real study. In 2016, the carcasses of reindeer that had died of anthrax in 1941 and then been preserved frozen in the Siberian tundra melted due to rising environmental temperatures. The anthrax spores contaminated nearby water and infected live reindeer grazing in the area. The infection soon spread to 2,650 animals, which comprised 6.46% of the susceptible population. Of the reindeer infected with anthrax, 2,350 died. Nomadic hunters contracted anthrax from the reindeer they rely on for food. 115 became ill and required hospitalization, and a 12-year-old boy died. The number of people in the hunting community wasn't reported, but let's assume 200, including 50 children. Calculate the attack rate for the migratory hunters. For attack rate, we're going to divide the number of people with an exposure who got sick by the total number of people with that exposure. So 115 people became ill and required hospitalization out of 200 people who were exposed. That gives us an attack rate of 57.5%. What is the pediatric mortality rate for this anthrax outbreak? For age-specific mortality rate, we're going to divide the people who died from that age group by the people in that age group. One child died, and there were 50 children in the community. So the pediatric mortality rate is 2%. What was the case fatality rate for reindeer? We're going to divide the number of reindeer who died during a specified time period following diagnosis by the total reindeer with the disease. We divide 2,350 reindeer by 2,650 for a reindeer case fatality rate of 88.67%. How many reindeer were in the population? They told us that 2,650 animals made up 6.46% of the susceptible population, so we can cross-multiply and determine there were 41,021 and a partial reindeer in the total population. When I did this math, I was really concerned that this made no sense, and I went back to the paper, and the authors wrote that they estimated 41,001 head of reindeer. This is an example where if you are looking at something and your answer doesn't make any sense, check your math and then also read if there's a footnote, because these authors may have used statistical methods to estimate the populations of reindeer in a geographic area that they didn't actually count the reindeer in. That might be the reason for this, but having 2/3 of a reindeer is kind of a red flag that something doesn't make sense. 80% of the antibiotics sold in the United States are consumed by feed animals such as cattle, chickens, and pigs, not by humans. Of the antibiotics given to animals, 70% are considered medically important because they are also used in human medicine. Feeding antibiotics to animals to increase large-scale production in confined, unsanitary conditions has both direct and indirect impacts on human health. Bacteria are able to share resistance plasmids with other species, allowing for resistance to spread in unpredictable ways once it develops. In 2018, California banned routine preventive use of antibiotics in food animal production without a veterinarian's prescription. In 2023, a study found a 7% reduction in resistance to cephalosporins among people with urinary tract infections attributed to this state policy change. An outbreak of highly virulent, multi-drug resistant E. coli linked to beef from Colorado was reported by Alaska Department of Health on Monday. You work at Nome Public Health Center, serving a census area of 9,865 people. On Wednesday, 140 cases have been diagnosed at the hospital, and 80 additional cases were diagnosed by rural community health aides. An estimate based on local beef sales since the contaminated meat arrived indicates about 4,000 people have been exposed. The incubation period is 3 to 4 days with a range of 1 to 10 days. Illness duration is 5 to 7 days. The clinical presentation is watery diarrhea progressing to bloody diarrhea after 1 to 3 days with abdominal cramps and pain, low-grade fever, and hemolytic uremic syndrome in 6% of cases. The transmission is by fecal-oral route through the consumption of contaminated food or water, through person-to-person contact with animals, or contaminated surfaces. Assuming there was no pre-existing E. coli in the population, what is the incidence proportion for these first 3 days of the outbreak? We would divide the number of new cases during the specified time interval by the number of people at risk during that time interval. Adding the 140 cases from the hospital plus the 80 cases diagnosed by health aides divided by the people in the census area, we'd get an incidence proportion of 2.23 per 100 over 3 days. In this scenario, we would want to include the total population, not only the people who bought the meat, because it isn't only spread by consuming the infected meat. Household contacts and other people in the community would also be at risk of infection. 320 more incident cases are reported by Friday. What is the incidence proportion for Thursday and Friday? We divide new cases during the specified time interval by the people at risk during that time interval. This time we're going to divide the 320 incident cases not by the total population, but by the people in the population who have not already become infected during this outbreak. That gives us an incidence proportion for Thursday and Friday of 3.3 per 100 over those 2 days. 1 month later, the outbreak is over, and 1,080 cases of E. coli linked to beef were diagnosed. What is the attack rate? We divide the people with an exposure who got sick by the total people with that exposure. In theory, we would want to be able to put only the people who were exposed in the denominator. This made-up example isn't perfect because we wouldn't know that only the people who bought the meat were exposed, but for the sake of this practice problem, we would divide 1,080 cases by 4,000 people that we believe were exposed. That gives us an attack rate of 27%. Revisiting the diagram depicting the natural history of disease, TB is an interesting example because there's multiple different possibilities for how the disease may progress. If someone gets exposed to TB in the air, their immune system may immediately clear the bacteria and they may not get infected. Or the person can develop latent infection where they have no symptoms, and only about 10% of the people who develop latent infection will eventually progress to active infection, but that usually takes many years and often only happens in people who get cancer or HIV or have some other condition that's compromising their immune system. Otherwise, the people with latent infection may never become infectious and may never actually become sick with TB. The third scenario is people can get exposed and then immediately develop active infection. With pulmonary TB, that means people would be breathing out infectious particles and can infect others. If the immune system can't immediately clear the slow-growing bacteria called Mycobacterium tuberculosis that causes the infection, white blood cells attack it in the lungs and encapsulate it in a ball called a tubercle that can stay there for years. And if the bacteria later break out of the tubercle, or if the person gets active disease right away, they may have a persistent cough, chest pain, coughing up blood, fever, weight loss, and fatigue. People with active pulmonary tuberculosis infection pose a public health risk because they may infect household members or other community contacts. Historically, TB prevalence in Alaska has been much higher than the rest of the US. It declined dramatically in the 1950s, but it's still higher, especially in the Southwest. We had a recent increase in TB in Alaska in the past few years, which has mostly been attributed to a pause in the community screening program during the COVID-19 pandemic. And that same program also provides direct observation therapy to treat both latent TB and active TB cases. I've gotten to do some checkup appointments for people undergoing treatment for active TB in Alaska at rural clinics, which is interesting because Alaska handles direct observation therapy differently from more urban areas of the US. For example, in Baltimore City, community health nurses would usually go to the houses of people with active TB to do the direct observation therapy. But at rural communities in Alaska, the state epidemiology program has a team that manages TB treatment remotely, and lay people in the community often do the direct observation therapy. I posted a video from KYUK Media that provides a really nice overview of the history of TB in southwestern Alaska. Here's a practice problem. If there are 200 people on St. George Island and the state's TB program found 5 cases of active TB when they resumed community screening after the pandemic, what is the point prevalence in 2023? We would divide 5 by 200 and get 2.5 cases per 100 people. Here's a couple questions for you to think about on your own. If cases of latent TB are included, how will this affect prevalence? How would including latent TB cases affect incidence if those individuals are no longer at risk of new TB infection? To recap, so far in the course, we've discussed the purpose of epidemiology, measures of morbidity and mortality, and ways of measuring the distribution of disease in populations. Next class, we'll talk about public health surveillance and the importance of evidence and data sources.